What we did was we used a test that is commercially available called Oncotype DX, which allows us to predict better which patients will benefit from chemotherapy or not, which patients with a particular sort of breast cancer, with hormone receptor positive breast cancer. It's been tested in patients with ER positive, HER2 negative breast cancer, in node negative and also some node positive patients. It's NICE approved for patients who have an intermediate risk of recurrence and who have ER positive, node negative breast cancer.
In the original trials, it was estrogen receptor positive patients they looked at, and the subgroup that was HER2 positive that they've subsequently looked at were predominantly high risk, and we now know they need chemotherapy. So there's no point in doing it in HER2 positive patients because you're always going to use chemotherapy there. So it's really the estrogen receptor positive, HER2 negative, so you're selecting the patients to have the test who you want to know the information on rather than doing it unnecessarily in other patients.
We use chemotherapy for people with early breast cancer to reduce the risk of their cancer coming back, and traditionally we've based decisions around size of cancer, for example nodal status, and use that to predict the risk of their cancer coming back. But this allows us to tailor chemotherapy, the use of chemotherapy, more carefully, so we only use it in patients who are more likely to benefit from it, and so we can avoid chemotherapy for some patients.
So if you like, we used to use anatomic factors, node, stage, grade, that don't relate to the biology of the tumour. Predict, which is an online index that allows you to calculate the percentage benefit of chemotherapy, is a way of doing it with taking into account estrogen receptor status, but this is actually looking at the molecular biology, the genes that the tumour expresses, and therefore will they respond or will they not. And it also flips the other way around, which is that if you are low risk on the low recurrence score with this test, you have a higher chance of responding to hormone therapy, so that actually you have more assurance that you will have a low risk of recurrence and a better response.
It was about 67 patients and who we would otherwise have given chemotherapy to, so they had to have a 5% benefit from chemotherapy. So by treating a 5% benefit would be treat 100 women, 5 extra lives are saved by giving chemotherapy. So that would be our normal decision around whether somebody should have chemotherapy or not. And we used the Oncotype DX test for all of these patients, and out of all of these patients, 2/3 of the patients then we were felt able to avoid chemotherapy on.
Provided you've selected them because you would have given them chemotherapy in any case, so you've selected a group of population that you would definitely have given chemotherapy. And the other thing to be said about it is both the patients accepted the results of the test, either had chemotherapy or didn't according to the results of the test, and the consultants who were dealing with them accepted the results of the test. So it had widespread acceptance as correct, which I think is important if you're going to use a test. You have to believe in the outcome of the test and act on it.
I think that's right, and I think patients, because lots of patients don't want to have chemotherapy, and it really helps them to feel that they should have chemotherapy if it comes back as a high score, and obviously saves a lot of people from having chemotherapy as well. So.
The flip side to it is there are, as Anne says, a lot of people don't want chemotherapy, and some people go to the end of the earth to avoid it. But if you can say to a patient, look, you're in the high risk category, you've got a high score greater than 31, you've got a 30% benefit from chemotherapy, not just the online prognostic index of 5%, it's 30%, most people will then accept they've got to have chemotherapy. So it helps you push people into having it where they are high risk. And that also makes us feel more comfortable about recommending it then. Young women on the whole are more often grade 3 and have more often biologically active treatment. The question you're asking really is, if you have an estrogen receptor positive, HER2 negative tumour, does it matter what age they are? And the answer is no. So I've just had a 26-year-old who had a grade 2 tumour that was 15 millimetres and was node negative, and we did a Oncotype DX test on her. Score comes back at 12, low risk. We're not going to give her chemotherapy because she is actually in the good type. And you do see some, they're less in that young age group, but age by itself, like many of the anatomical factors, isn't a predictor of the actual behaviour of the tumour.
If you use Oncotype DX on the right population of patients, so that's ER positive, HER2 negative patients, then it is very useful to allow you to make better decisions about whether the patient should go through the rigour of chemotherapy or not.
So I totally agree that it allows patients that need chemotherapy to get it and those that don't to avoid it. It gives people high confidence of the decision you've made rather than where you were prognosticating with 5% benefit or not, where it was very difficult to make those decisions. I think we've also used it, and we've discussed this, in some node-positive patients, not where NICE is indicating it, but there are node-positive patients who have other comorbidity where you really do need to know what the benefit of chemotherapy would be, and in that situation it works equally well, and there's data that it does. So I think it probably could be used more widely, but in the UK it will be according to NICE guidelines initially.
Yeah, but it would be very nice to use it in the very elderly population who you actually want to avoid chemotherapy on unless you really need to give it.
Very easy to use, yes. You send a request to the pathologist, they send the blocks off, it's sent back to you on an online account so you can see it by email within 10-14 days. Talk to the patients when you've got the results. They're delighted on the whole. They really like it. It's much better.
And if you're organised with your pathway, then it doesn't delay chemotherapy, because what patients don't want to do is delay things either. But if you see people early and get it sorted, you don't delay treatment either. So
I think the key to that is in the MDT we say we want an Oncotype DX test. The surgeons will then order it via the pathologist. It will happen from the MDT saying they want one, and really the test will be available before they're due to see an oncologist. So that's great, and that works for all of us, and it means the surgeons are getting familiar with how the test works as well as the oncologist.